Seronegative rheumatoid arthritis, RA, refers to a type of rheumatoid arthritis in which patients test negative for rheumatoid factor RF and anti-citrullinated protein antibodies, ACPA, commonly used markers to diagnose RA. Despite the absence of these markers, patients with seronegative RA still exhibit the classic symptoms of RA, such as joint pain, swelling, and stiffness, especially in small joints like hands and feet, symmetrical joint involvement, morning stiffness lasting more than 30 minutes, fatigue, and general malaise. Differences between seronegative and seropositive RA. Diagnosis. Seropositive RA is associated with positive RF and ACPA tests, whereas seronegative RA lacks these markers, making diagnosis more challenging. Disease course. Some studies suggest that seronegative RA may have a milder disease course compared to seropositive RA, although this varies between individuals. Extra-articular manifestations. These tend to be more common in seropositive RA, such as nodules and lung involvement. Management. Treatment of seronegative RA generally follows the same principles as seropositive RA, including the use of disease-modifying antirheumatic drugs, DMARDs, like methotrexate, biologic agents targeting specific immune pathways, e.g. TNF inhibitors, nonsteroidal anti-inflammatory drugs, NSAIDs, and corticosteroids to manage symptoms. The absence of serological markers requires a greater reliance on clinical presentation, imaging like ultrasound or MRI, and response to treatment to confirm the diagnosis. Would you like to dive deeper into specific aspects of seronegative RA, such as imaging, treatment approaches, or prognostic factors? Let's delve deeper into key aspects of seronegative rheumatoid arthritis, RA, focusing on imaging, treatment approaches, and prognostic factors. Imaging in seronegative RA. Since seronegative RA lacks the typical serological markers, imaging plays a crucial role in diagnosis and monitoring disease progression. 1. X-rays. Early in the disease, X-rays may show no abnormalities, but as the disease progresses, joint erosion and narrowing of the joint space can appear. Compared to seropositive RA, joint damage may occur at a slower rate, though this is not universal. 2. Ultrasound, useful in detecting early synovitis, inflammation of the joint lining, and effusions, fluid in the joints. Power Doppler ultrasound can assess blood flow, indicating active inflammation, even when clinical signs are mild or absent. 3. MRI, magnetic resonance imaging. MRI is highly sensitive in detecting early joint inflammation, including bone marrow edema, which indicates active inflammation and may predict future joint damage. MRI can reveal subclinical synovitis and early erosive changes before they are visible on X-ray. Treatment approaches. While the management of seronegative RA largely mirrors that of seropositive RA, certain nuances should be considered. 1. Disease-modifying anti-rheumatic drugs, DMARDs. Methotrexate remains the cornerstone of RA therapy, whether seronegative or seropositive. It is often used as first-line treatment. Other DMARDs include sulfasalazine, leflunomide, and hydroxychloroquine. 2. Biologics and targeted therapies. If DMARDs are insufficient, biologics such as TNF inhibitors, etanercept, infliximab, IL-6 inhibitors, tocilizumab, or JAK inhibitors, tofacitinib, are options. The response to biologics in seronegative RA can vary. While some studies suggest that seropositive patients may have a slightly better response to biologics targeting B cells, like rituximab, seronegative patients can still benefit from a range of biologic treatments. 3. Corticosteroids. These are often used for short-term relief of inflammation, but long-term use is avoided due to potential side effects. 4. NSAIDs. Useful for controlling pain and inflammation, though they do not alter disease progression. Prognostic factors. Disease severity. On average, seronegative RA is thought to be less aggressive than seropositive RA, though this is not always the case. Seronegative patients may have less severe joint erosions and a lower likelihood of extra-articular manifestations, e.g. rheumatoid nodules, lung involvement. However, joint damage can still occur, and disease progression needs to be monitored. Response to treatment. Seronegative RA patients may show variability in their response to certain biologics, particularly those targeting B cells, like rituximab, as B cell activity is more strongly linked to seropositive RA. Some studies suggest that seronegative patients may have a quicker response to DMARDs like methotrexate, though long-term outcomes are similar to seropositive cases. Prognosis and disease outcome. Overall, the prognosis is somewhat better in seronegative RA compared to seropositive RA, but the disease can still cause significant joint damage and disability without appropriate treatment. Conclusion. Seronegative RA, while lacking the typical serological markers of RA, can still cause significant joint damage and disability. Imaging plays a critical role in diagnosis and monitoring, and treatment is similar to seropositive RA, relying on DMARDs, biologics, and symptomatic treatments like NSAIDs and corticosteroids. The prognosis may be slightly better, but early diagnosis and aggressive management remain crucial. Would you like to explore specific treatment options, such as newer biologics or the role of physical therapy in seronegative RA? The idea that seronegative rheumatoid arthritis RA is generally better than seropositive RA in terms of prognosis and response to treatment is a myth with some nuances. While there are some differences between the two, it is overly simplistic to say that seronegative RA has a universally better prognosis or response to treatment. Let's break this down. Prognosis: joint damage and disease progression. It is often said that seronegative RA tends to be milder and less aggressive in terms of joint damage and disease progression. However, this is not always the case. Some seronegative patients still experience significant joint destruction, and the disease can progress just as aggressively as seropositive RA in certain cases. Seropositive RA, particularly in patients with high levels of anti-citrullinated protein antibodies, ACPA, and rheumatoid factor, RF, is more commonly associated with severe joint erosions, extraarticular manifestations, e.g., nodules, lung disease, and overall worse outcomes. Extraarticular manifestations. These tend to be more common in seropositive RA, including lung involvement, vasculitis, and rheumatoid nodules. Seronegative patients typically have a lower risk of these complications, which contributes to the perception of a better prognosis. Response to treatment. Methotrexate and DMARDs, both seronegative and seropositive RA patients respond well to methotrexate and other DMARDs, disease-modifying anti-rheumatic drugs. However, seronegative patients may respond faster in some cases, though long-term outcomes are similar. Biologics. Some studies suggest that seropositive RA patients, particularly those with high levels of RF or ACPA, respond better to B-cell targeting biologics, like rituximab, as these antibodies are produced by B cells. On the other hand, seronegative patients might have a comparable response to other biologics like TNF inhibitors, etanercept, infliximab, or JAK inhibitors, tofacitinib, though results can vary. Long-term outcomes. Over time, the difference in treatment response between seropositive and seronegative patients tends to diminish, with both groups having similar long-term outcomes, depending on the aggressiveness of the disease and how early it is treated. Key takeaway. The idea that seronegative RA has a universally better prognosis or better treatment response than seropositive RA is a myth. While some seronegative patients may have milder disease, the variability in disease severity means that many seronegative cases can still progress aggressively and require the same level of intensive treatment as seropositive cases. Would you like more information on specific biologic therapies or differences in disease manifestation between these two forms of RA? Yes, seronegative rheumatoid arthritis, RA, can be positive for other markers besides rheumatoid factor, RF, and anti-citrullinated protein antibodies, anti-CCP. While RF and anti-CCP are the most commonly used antibodies in diagnosing RA, seronegative RA may involve other immune markers or inflammatory indicators. These include SHAR1, acute phase reactants, C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR. These are nonspecific markers of inflammation that are often elevated in RA, including seronegative RA. While they do not confirm RA, elevated levels can suggest the presence of ongoing inflammation. 2. Anti-nuclear antibodies, ANA. ANA positivity is more commonly associated with other autoimmune diseases, such as systemic lupus erythematosus, SLE. However, some patients with seronegative RA may have positive ANA tests. This can sometimes complicate the diagnosis, as ANA is not specific to RA but can be present in various autoimmune conditions. 3. Anti-carbamylated protein antibodies, anti-CARP. Anti-CARP antibodies have been studied as an additional marker in RA and can be present in both seropositive and seronegative patients. These antibodies are associated with more severe joint damage and could potentially help in diagnosing seronegative RA or predicting its progression. App 4. Other autoantibodies. In some cases, anti-Rho SSA antibodies, typically associated with Sjogren's syndrome or SLE, may be found in patients with RA, including those with seronegative RA. Anti-RA33 antibodies. Although not routinely used, these antibodies have been identified in some RA patients and could be present in seronegative cases. 5. HLA genetic markers. Certain HLA, human leukocyte antigen, genetic markers, particularly HLA-DRB1, are strongly associated with RA. Even in seronegative patients, the presence of specific HLA alleles, especially those referred to as the shared epitope, may increase susceptibility to RA. 6. Other inflammatory markers. Elevated levels of other inflammatory cytokines, e.g. IL-6, TNF-op, can also be seen in seronegative RA, although these are not specific to RA and are not typically used as diagnostic markers. Importance of clinical features and imaging. Since seronegative RA lacks RF and anti-CCP, diagnosis often relies heavily on clinical presentation, symmetrical joint involvement, morning stiffness, etc., and imaging findings, e.g., joint erosion, synovitis on ultrasound or MRI. These indicators are crucial in confirming the diagnosis when traditional serological markers are absent. Conclusion. While seronegative RA is negative for RF and anti-CCP, other markers like CRP, ESR, ANA, and anti-CARP antibodies can still be present. These may help in diagnosis or provide insight into disease severity and progression, but they are not definitive for RA on their own. Would you like more information on how these markers are used in clinical practice, or details on specific genetic testing for RA? Let's explore in more detail how these markers and genetic tests are used in clinical practice for the diagnosis and management of seronegative RA. 1. Acute phase reactants, CRP and ESR in clinical practice. C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, are both commonly used to assess the level of inflammation in the body. In the context of seronegative RA, these markers are not diagnostic but serve as supporting evidence when elevated. They are useful for tracking disease activity and guiding treatment decisions. CRP. This rises quickly in response to inflammation and is useful for short-term monitoring. ESR. This marker rises more slowly but stays elevated for longer, reflecting chronic inflammation. In seronegative RA, persistent elevation of CRP or ESR can indicate ongoing disease activity and the need for more aggressive treatment. 2. Anti-nuclear antibodies in clinical practice. ANA testing is more specific for diseases like lupus, but can sometimes be positive in seronegative RA. When ANA is positive, clinicians may also consider overlapping autoimmune diseases, such as Sjogren's syndrome or mixed connective tissue disease. If ANA is positive in a seronegative patient, further testing, e.g. anti-Rho antibodies, anti-dsDNA, might be necessary to rule out or confirm other autoimmune disorders. Positive ANA alone is not enough to diagnose RA, but can provide clues for differential diagnosis. Anti-carbamylated protein antibodies, anti-CARP, in clinical practice. Anti-CARP antibodies are not routinely tested in clinical practice, but are gaining attention for their association with RA, especially in seronegative patients. These antibodies can help predict the severity and erosive nature of the disease. For patients who are seronegative but show strong clinical signs of RA, anti-CARP antibodies can help support the diagnosis and indicate a more aggressive disease course. 4. Genetic testing for HLA markers, HLA-DRB1. The presence of specific HLA-DRB1 alleles, known as the shared epitope, is strongly associated with the risk of developing RA. Patients who are seronegative but carry certain HLA alleles, especially HLA-DR4 and related subtypes, may have a higher genetic predisposition to RA, providing genetic evidence to support the diagnosis. Genetic testing for HLA markers is not part of routine RA diagnosis, but can be useful in research settings or for patients with an unclear diagnosis. In seropositive RA, the presence of HLA-DRB1 alleles is strongly linked to ACPA positivity. However, in seronegative RA, these alleles are still found and can help predict disease severity and response to treatment. 5. Other autoantibodies. Anti-Rho SSA antibodies. While more common in Sjogren's syndrome and lupus, these antibodies can sometimes be found in seronegative RA patients with overlapping features of other autoimmune conditions. Anti-RA33 antibodies. Although not commonly used in clinical practice, anti-RA33 is another marker that may be present in both seropositive and seronegative RA. Role of imaging in clinical practice. When serological tests are inconclusive, imaging plays a vital role in diagnosing and monitoring RA. These include ultrasound, detects early synovitis and joint effusions, particularly useful for identifying active inflammation that may not be apparent on physical examination. MRI, used for detecting early erosive changes, especially in small joints, and assessing the presence of bone marrow edema, which is a sign of active inflammation. Imaging helps to visualize joint damage and can confirm the presence of inflammation, supporting the diagnosis when serological markers are absent or negative. Conclusion. In clinical practice, acute phase reactants like CRP and ESR, ANA testing, and genetic markers such as HLA-DRB1 are all tools that help in diagnosing and managing seronegative RA. Anti-CARP antibodies offer additional insight, especially when typical markers like RF and anti-CCP are absent. Together with imaging, these tests help build a comprehensive picture for diagnosing and monitoring seronegative RA, guiding treatment decisions based on disease activity and progression.